Good evening, everyone. It's a pleasure to be welcoming all of you to the very first mini-med session for 2022. A very chilly night and a very good place to be. I want to welcome you on behalf of myself, Dr. Roseanne Berger. I'm the director of the Mini Medical School, and would like to say that I admitted each and every one of you as students to this course, but our admissions committee consisted of other people. Jen Britton is with us, and as many of you know, she is our ally in Mini Medical School from the Office of Advancement, and of course, our Mini Med Advisory Board, who helps us select programs that are really of interest to all of our students, including all of you. So this year's, we have spent quite a bit of time in our first semester focusing on nutrition and disease states and how nutrition can affect it. We're launching the second semester with a focus on diabetes, which is really becoming increasingly more rampant in our population. It has an interesting history, and we will learn about that from our speaker this evening, who's Dr. Antoine Makdissi. Dr. Makdissi is someone that I value very much as a consultant and somebody that I could call on the phone for advice. He is a clinical associate professor in the Department of Internal Medicine, an endocrinologist, and a clinical researcher as well, who's done some interesting work on medications that are used for type 2 diabetes and whether they are applicable to type 1 diabetes. So hopefully you'll be able to talk about that a little. As usual, I want to thank you all for sending in questions in advance. We were able to share those with Dr. Makdissi, and he has incorporated the responses to many of your questions in his talk this evening. So keep your ears open in case he answered your questions. We will also accept additional questions in the chat, and if there is time, we will get to those. We hope we can. We will post this on our Mini Med website, as we have with our other sessions. There will not be a test tonight, but you never know when we will be sending out a test, if not an evaluation at the end of this course. Thank you to UBMD and Independent Health. It really means so much to have financial support for this program, and we thank you very much. So without further ado, I am going to turn the Mini-Med classroom over to our professor of the evening, Dr. Antoine Makdissi.
Thank you very much. I'm really honored that I've been tasked with this presentation here, and I hope that you find it helpful. So let me start. Okay, so I'm going just to start a little bit now with the journey that we will be on together for the next hour or so, or hour and a half. So obviously there's a lot of questions, but I really wanted to address it in a very sort of focused fashion. Why diabetes? Why are we talking about it? First is, why does diabetes happen, and why should we care? Why do we have to address it? And just to touch upon, how big of a problem our society is facing. And my focus is going to be primarily on the type 2 with type 2 diabetes primarily. So a lot of these slides are going to be focusing on that aspect. Similarly, now the next thing would be, now that we know how big of a problem is, so how can we be prepared to deal with it? And I think always the prevention is the key. So we're spending some time talking about how do we prevent diabetes. And then if we have the condition, how do we manage it? And the management is multiple steps. Starts by monitoring, because once we know what we're dealing with, we'll be better prepared. So how to monitor some of the lifestyle changes and take home messages. Then we talk about what has changed as far as the medications available and the focus in for us as a provider, how we are able to work with the patients. To focus to prioritize primarily how to approach it. Briefly, we can spend if we have any questions about metabolic surgery, and then some of it based on the questions that we received already regarding the research that's being done, some of the new interesting molecules that have been identified, and the molecules called FABCAN. And then some of the newer technologies available to us and to the patients, how to monitor and help, adjust the medications based on the glucose level. Again, focusing on the treatment, how we can change that, our thought process in terms of the choice, which medication do we, choose next. And then definitely in this day, what we've been through over the past, couple of years together, and how has the epidemic impacted the diabetes. So we'll spend a few moments also talking about that. So obviously, just to remind everyone, the journey to diabetes, really, if we are gonna kind of separate, first we have to decide as to what is the cutoff point where we're considered normal. So now we have obviously three things that we can do, either by checking the blood sugar itself, the level, or we can do a test, which is called the hemoglobin A1C test, or we can do something a little bit more dynamic where we can ingest glucose, and then we can see how the response of our body to that challenge, if you will. So first, the normal starts, if we look at the glucose level, should be 99 or below. If we use the A1C test, it should be 5.7% or below. And if we are taking that 75 grams of glucose or the sugar, and we check the blood sugar 2 hours later, then really normally our blood sugar should not rise more than 140. And then on the way to develop the diabetes, we pass through a stage of pre-diabetes, and we can have, those ranges as I highlighted, whether it's on the A1C, on the glucose test itself, or the challenge, and those are the ranges. And then the diabetes, as you can see, where we can, those are obviously higher ranges for the A1C to be 6.5 or above, the glucose fasting 126 or above, or if we reach above 200 on the glucose tolerance test. Now, some would ask, what is really the A1C? What is the difference between the A1C test and what is the difference between the glucose and how is that different between that and to the glucose level itself? So I always kind of try to, look at it as the blood sugar is almost like taking a picture at that moment in time. It gives me an idea of what exactly that happened that moment, that minute, that second, if you will. Just taking exactly a capture really a photograph. And so it represents only what happened that time. Whereas the A1C test gives us an idea of what has happened over the past 3 months or so. And the premise is that if you look at this, slides our red blood cells, in our red blood cells, there is the hemoglobin, and the blood sugar is kind of circulating in the bloodstream. And some of that blood sugar attaches to the hemoglobin inside, the red blood cell, and we can measure the percentage of that hemoglobin that is, pretty much has been attached to the sugar. So the higher the blood sugar for the longer period of time, that gives us a higher A1C. And the table that you see kind of gives us an idea. Some of it is the international unit. So if and I don't know if we have any international, audience from outside the US, but across from Canada, they use that system. But if you focus on the second column, you can see what is the average, anticipated average blood sugar based on the A1C test. So we use, as I mentioned earlier, we can either use the A1C itself as for the diagnosis and the monitoring, or we use the, the glucose level. And we really do need both and to assess the, overall state of how our blood sugar control is and has been. Now, so going back to the questions as to why diabetes happens, and if you see based on this, there's a number of defects that can happen, or problems that could happen in our body that can result in the blood sugar increasing above the normal range. And even though that slide appears to be busy, but really, if you focus on a couple of aspects, one is the the insulin production from the factory, from the from the pancreas, from that those cells that are specialized in making the insulin. That is one problem, and a significant problem. But then every other organ could be impacted in that, from the liver to the kidney to the muscle to the fat tissue that we have. To, believe it or not, or our
it's just like buying and selling anything, right?
Sorry, was there a question? Okay. So to our GI system, and so essentially all these could happen in order for the blood sugar to increase. So there is as I mentioned, there is a deficit, with the insulin release, so the insulin production, or there is a resistance to the action of the insulin. So for instance, this type 1 diabetes, we have a problem primarily in the release of the insulin. In type 2 diabetes, we have a combination primarily in the, on the resistance aspect to the action of insulin. That's not to say that patients with type 1 can have resistance, and patients with type 2 also can have sometimes deficit in the production of the insulin. As far as how big of the problem is, so you could imagine how in the United States right now we're facing really, and this epidemic has been happening and growing every year. And currently, it is expected that 1 in 3 patients actually does have a pre-diabetes. So that will amount about 88 million people in the US alone. And the challenge why that is important, because obviously, as you've shared with you earlier, is that pre-diabetes will eventually develop to a type 2 diabetes, and that is considered a significant risk for heart disease and stroke. So this is really why it is such a huge problem, that we are actually facing at the moment. But the interesting thing, so the positive aspect of things is that if one has a pre-diabetes, simply making the lifestyle changes, eating healthy and being more active, can cut the risk of getting or developing to type 2 diabetes in half. And this is based on this major or significant really clinical studies done early and finishing in 2002, published, showing how this happened. They have enrolled more than 3,000 people, and they've kind of split them in 3 groups. And they asked, if a group is just to do regular, they gave them some generic advice, and they gave them a placebo pill. And then the second group, they gave, in addition to the advice, they gave them the medication, which is called metformin, that is used for treatment of diabetes. And then, the third group, they provide them with sort of somewhat, intensified lifestyle program consisting of dietary and counseling and a much more regular activity. And so they followed these, patients or subjects for the duration of the study. And as you can see, as the years went by, the people who participated in that lifestyle, what we call it arm of the study, they had a 58% reduction of developing diabetes for the duration of the study. So And this is how the diabetes or the diabetes prevention program of the DPP program really was born based on the design of this clinical study, which is a landmark study in a sense. And therefore, the CDC has created the National Diabetes Prevention Program, as I mentioned, based on that protocol from the study. And I wanted just to share with you a small video, which is, you can see there's a lot of information on the CDC website regarding diabetes, prediabetes, how to, what are those conditions, and then how can we participate in these programs, if you will. So this is what you will see for those of you who are interested to explore a little bit more. But this is a sample of what you might see on that website. So I'll share with you that video for the next couple of minutes.
Staying healthy can seem complicated, especially if you have prediabetes. Prediabetes puts you at risk for developing type 2 diabetes, a serious health condition. That's why CDC developed a lifestyle change program to help you reduce your risk of type 2 diabetes and improve your overall health. This program will take the guesswork out of losing weight, eating better, and being more active. You'll learn new ways to stay healthy and sustain those changes over time, such as how to exercise when you can't go outside, and how to eat healthy even on your busiest days. When you join, you'll get a full year of support from a trained lifestyle coach to help you set and achieve realistic goals, keep you motivated, and manage stress. Through this program, you'll learn, laugh, share stories, try new things, and build new habits, all while lowering your risk of type 2 diabetes and improving your health. You can even join the program with your friends or family members at risk for type 2 diabetes and prevent the disease together. You will meet in person or online about once a week during the first 6 months of the program, and then have monthly sessions for the rest of the year to help your new, healthy habits stick and keep you from slipping back into old habits. During the program, you'll have the chance to talk privately with your lifestyle coach. As a group, you'll discuss the challenges you face in losing weight, eating healthy, and increasing your physical activity. And your coach will help you overcome any obstacles that get in the way of your success. This program has already been proven to work for thousands of people. Will you be next? Visit cdc.gov/diabetes/prevention to learn more, or talk to your healthcare provider about getting tested for prediabetes.
So what it is, for anybody who's interested, obviously they can go online, they can take a test, they can, see what the risk, if they are at risk of developing prediabetes, if they do have prediabetes, and you can certainly actually search, the area where you're in and see which, which participating entity do offer that program, and we were proud to offer that program in our center a couple of years ago, and we can continue to work on offering that for people, those who are interested. And as you heard it, this is a long program. It's not just one session or 2 sessions, but there are multiple parts, multiple places in Western New York that you can just search by the zip code and you can find where that is. A lot of it is based on the community centers or some of other practices. But the interesting part is, as I mentioned earlier, is that program, that study ended in early 2000. And what the CDC has been doing ever since has been kind of following. After the end of the study, they offered the lifestyle change program slightly modified to all the patients, and they have been the same kind of following them in that group over the years, and we have now information over the 15 years or so of following these patients. And the nice thing about it, is, as I mentioned initially, a small change, and this is exactly the message that I want to convey, is we don't have to have, incredible expectations and goals of losing, 20% of the body weight. 5 to 7% loss of body weight, can reduce the risk by 58%. So that's kind of the message I try to share with my patients a lot. So we can have a realistic expectations and in reality really achievable. And that program really worked well for those patients who are above 60. They have even benefited further, and they've reduced the incidence of the developing type 2 diabetes by 71%. And as I mentioned, after 15 years, a lot of these patients obviously are still being followed, and the good thing is that they continue to do well. And there's the patients who have and continue to participate in a modified lifestyle program, they have achieved 27% lower incidence of type 2 diabetes. So I wanted just to spend a good time on this because this is essential. I think obviously, there's a lot of factors, obviously genetic factors, that can impact on who does develop diabetes and who doesn't. But at least the stuff that we are able to modify, if we get on it earlier, we can hopefully decrease the disease burden, primarily obviously in ourselves, but also as a consequence on our society. And the reason I say that again, if you look at the statistics of the, the diabetes itself, then now if we move on from the pre-diabetes, there's about 34.2 million people currently estimated to be diabetic in the US. And this is 1 out of 10 patients, out of 10 people really. So this is the really staggering statistics, and this is really a true epidemic in a sense. And then if you take it, the impact on that health-wise, cost-wise, there's, the cost usually, for people with diabetes, there's like $327 billion cost. There's usually overall a higher risk, 60% higher risk of death in patients who are diagnosed with diabetes. And obviously the medical cost in general is double what, when you compare that with patients without diabetes. So it's really an incredible task that we have to face together in order for us to deal with it and reduce the burden on all of us, as I said, individually and as a society. Why that is important, because diabetes, not only the cost and the risk of death, but in general there's a lot of comorbidities that happen with it. There's a lot of potential complications, and especially if we leave it uncontrolled. So there's a risk of the blindness, kidney conditions, heart disease, stroke. And then obviously because of the damage to the nerves and so on, there's a lot of potential risk of amputations. And thankfully, even though they may still occur, but if we take care of the diabetes, we're able to reduce the risk of these complications. And that's another message, take-home message that I want to share is we do have now evidence that if we take care of the diabetes, if we control it well, we are able to reduce the risk. And if you remember that A1C that I shared with you, based on the studies now that are being conducted in the late 90s and more, data still come out from those. If we 1% reduction in that A1C, when we have the diabetes, we can reduce. You can see that there is you choose whether it's a death risk reduction, heart attacks reduction, microvascular. Those are the tiny little blood vessels that supply the back of the eye, the retina layer, the nerves, or the small blood vessels in the kidneys, or the big blood vessels that, the peripheral vascular disorders, those are the arteries that are supplying the blood down to the limbs and the legs and so on. So there is a clear evidence right now, if we do control the diabetes, we are definitely going to reduce the risk of this, the complications of that. So it is a big problem, but we know if we take care of it, then we are less likely to, face the complications that comes, from that condition. So what do we do, as the healthcare professionals, how do we deal with that? Obviously this is, there's a number of professional societies that publish for us, guidelines and to how to take care of patients with diabetes. And this is really sort of the manual that comes out every year. This is our, first Christmas gift, if you will, for us, as the providers. We get it, and we kind of go through that, to see what's new, what is updated, and this is published for 2022 now. So what's changed? Obviously, this is a very busy slide. I'm not going to cover every word in it, but the message that has been now, and which has always been the case, but it's been more emphasized, most later to us. It's not like we just have to look at the number. We're going to have to put the patient back in the center of that, of the treatment plan, of the care. And that's what the slides is all about. We're, yes, looking at the A1C, look at the numbers, but we really should not focus on that alone. We really have to get that patient back in the center and then work with the patient to formulate the plan. And based on that, the chance of success is much higher. So that message now is being, over and over again over the past several years, being emphasized with a lot of these professional societies, to get that, to come across to all the providers. And so what does that mean? Well, and again, what is that? Obviously you hear, what should my A1C be? What should your target A1C be? We get that question every day, whether it's from our patients or from our colleagues. What should I get? Or from our students and residents and fellows. What should we aim? What A1C should we aim? And the answer really is not one size fits all. So as we speak to the patient, we really have to consider all these factors that you see that, right? So there are certain factors that we can, change. And there are certain, factors that, we have somewhat control over. So, and it may not be obvious when we talk to the patients, but that's kind of what's going on in the back of our mind. When we ask the patient, how long have you had the diabetes? We have to look at what other medical problems. Does the patient have a cancer? Does the patient have a heart disease? Does the patient have kidney disease? Then the question is, what kind of support do you have at home? What kind of support do you have financially and coverage wise? And it doesn't mean financially just the mean of paying, but also simply support of who's going to get the medications on time. How do you get that delivered? And then some of the comorbidities important, as I said, whether they have already, the patient has a heart condition. How is the vision? Can they see if we prescribe a needle? How is that going to be? Or if someone has already had a stroke, what is the chances of them successfully, dialing the dose of the insulin correctly? So, I cannot say, yes, everybody should be. I would love to say, and everybody, kind of say the same. We know the lower the A1C so far, when we lower the A1C, we seem to be preventing, several complications. But should we aim, to 6% to everyone? And we have to be realistic as well, because sometimes then if we aim to that lower target, we may be actually setting ourselves with a lot bigger problems. And the major problem would be is the hypoglycemia, the low blood sugar. So, again, this is what our, work we, as we talk to the patient, as I mentioned, we consider all these factors so we can involve the patient in the decision making and what would work best for them. So in general, when we talk about the management, there are three kind of pillars in a sense. There is the lifestyle change, which is, really the foundation to all what we talk, because yes, there are medications, and yes, there is even the surgery as an option. And oftentimes, we are going to do the medications, but, I can say, we're not really going to try to add more medicine to actually compensate for our lack of effort from the diet perspective and from the physical activity, perspective. Understanding we are all facing, multiple challenges, including the snow outside and the cold weather outside. We're not going to be as active in the winter. And this is a typical time of the year where it's very challenging to me personally, but also to a lot of our patients is, from the beginning, the football season, Thanksgiving, all the holidays until, until the, Super Bowl in a sense, this is really where, and the winter. So you can imagine how challenging that is to many of us, trying to get, and this is sort of the effect where we see a lot of the worsening glycemic control on a day-to-day. So medical nutrition, and what does that mean? Obviously, really, it's really the education to support helping the patients adopting the best health, conscious, eating pattern, if you will. And really, there's a couple of components: the diet quality, and then really the other aspect of it is sort of quality of food that we have. But the second aspect is the caloric restrictions. So, then the message that I want to leave, I think there has been, to my knowledge, there hasn't been really a superior diet. We get asked all the time, I'm going to do diet X, diet Y, diet Z, which one I should do, which one is better for me, which one is better controlling the blood sugar, and so on. And you will see in the literature a number of studies actually trying to point out, what is the benefit of this diet over this diet and so on. But the reality is, I think, and that's what, most of the dietitians will tell you, that when they meet with the patient, I think the first step is to understand, what does the patient do? Really, what do they eat? What is their food? And sometimes we have certain, ethnic, especially some of the people who haven't, they brought their ethnic food with them, and that's what they cook, and we can give them handouts. But if they are making a completely different component, so we really have to understand what the patient does first, and then kind of try to work with them as to where can we substitute the stuff that is really not helpful. And then, and this is where the introduction of a lot of the, the fruits and the vegetables, and then kind of trying to stay away from the harmful, and understanding that there's certain diet that tends to be, helpful a little bit, such as the Mediterranean diet, helping in reducing the high, the high blood sugar. So essentially, what you will hear that there is really no superior diet. Is just having to, take what the patient, work with, does, and then work with that to build, the diet on this. And sometimes this is disappointing to the patients, because a lot of our patients come to us and say, okay, give me a diet. I want to eat this on Monday morning, and then Monday afternoon, I want to eat that, and so on. And oftentimes that doesn't, it really doesn't work that way. So there is the quality of the food, as I said, what kind of the type of food, but then in general, just the caloric restriction. It is helpful. It does lower the blood sugar. Generally, if you lose the A1, there's in general, there's some studies showing that it can lower the A1C. This is proportionate to the weight loss. Obviously, with caloric restriction, there is a weight loss, and for every 9 kilos, which is close to 18-20 pounds, you will see an A1C reduction about 1%. There is a potential with that of kind of remission of the diabetes. You're modifying all the risk factors for the cardiovascular disease. And definitely when you do that, you're going to need less medications, right? So, as far as what caloric restriction diet, a lot of these commercial diets are actually built on that. They may not call it as a caloric restriction diet, but really many commercially available diets that you will hear advertised with, and we have a number of our patients, participate in, are based on caloric restriction. So taking the food and kind of, taking a smaller portion. So it's portion control, going back again to very basic principles. Sometimes you'll see the plate method where we can say, as far as the component of the diet, obviously, where is our, how our really meals should be, built. in a sense, and really you have to think about it is half of our plate should be vegetables, and those are non-starchy vegetables, and then the other half should be split in two portions. One is really carbohydrate, and then the other one is protein food. Now this is a plate, the regular plate. It's not a tray. This is this is just the regular plate, and trying to build that. And the carb amount for a lot of our patients obviously depends, as I said, depends on what they do historically, and what is the size of the patient to begin with. But oftentimes you'll see the range oftentimes is around 45 grams to 60 grams of carbs. And for those who are using the servings, so that would, typically around 3 to 4 carbs servings. Ideally, and you will see some of the recommendation focusing on the water instead of the juices. We're going to try to push, the patients to really, take away that, all these, juices, and even if it's fruit juice, right? I mean, it's oranges, well, understand, but you can have, it would be better off to have one orange instead of, having, a glass of orange juice, because then again, going back to the history of the caloric restriction. Carbohydrate counting, we try to work with our patients really a lot to push that concept, because it helps significantly trying to their kind of meal planning and our dosing for the medication, especially if someone is using multiple daily injections of insulin. So what I've mentioned to you is that there are two concepts. Either when you read the label, you can find out how many grams of carbohydrate the food contains, or you can just refer to it as for every 15 grams there is a carb serving. So generally speaking, we are going, the recommendations is going to be anywhere between 45 to 60, but obviously this is variable depending on multiple factors, and some people will need much more restrictive carbohydrate content per meal, and some people will have a lot more generous allowance to them. So these are some of the, kind of official guidelines from that book that I mentioned to you that comes out every January. And I wanted just to focus on a couple of messages because I think some of the questions have come in. So these are, again, just as emphasizing the point is there's really no ideal, some people say, I want to go to low carb, I want to go no carb, I want to go to keto, I want to, so, at the moment, really there is, for us as the providers, there is really no clear recommendations to, or guidance really for us to recommend one diet over the other. We just have to listen to the patient and see what works best for them. A number of, again, some of the, such as the DASH diet, and as I mentioned, Mediterranean diets have been also been really suggested as potentially reducing the risk of the diabetes and so on. But again, the goal overall is caloric restriction and overall reducing the carbohydrate intake. As far as the, we get a lot, we have a lot of these questions as well. Can I take any supplement to make my diabetes go away? Can I take my diabetes to get my sugar better? And as of now, as you can see from this slide coming from the American Diabetes Association, there is really no clear evidence that any dietary supplements with vitamins, minerals, such as the chromium, which is commonly asked by our patients, vitamin D, herbs or spices, such as the cinnamon or the aloe vera, can improve outcomes, in patients, in people with diabetes. If you do not have a deficiency of these, whatever vitamin that you're asking to take, right? So that's my general, response. In traditional medicine, this is the guidance that we have based on the research studies available to us. And I just ask patients, if you are taking something, just let me know what you are taking. Try to bring the bottle with you so I can include it in your medication list so I am aware of what you are taking. If I know of anything that there is evidence or suggestions that this could be harmful, I would advise so. Otherwise, if there is not clear benefit, I would clearly and be honest with the patients, sharing that with them. And then oftentimes, they'll have to make a decision whether they want to continue with that or not. But I would suggest that always kind of share with the provider who's taking care of this. The other thing is, as far as alcohol is concerned, I thought I should kind of share with you. Some of it may be already known. Moderation is the key. And just to be more specific, because I don't want to leave this saying that yes, you can go ahead and drink. So moderation is advised, defined here: no more than 1 drink per day for adult women, and no more than 2 drinks per day for adult men. And don't shoot the messenger. This is coming out from the ADA. This is the American Diabetes Association panel of experts. So this is really the recommendations. And I always say, try to have it with food if you're going to enjoy, a glass of alcohol, whichever, your preference is. But then I think the message really is unbelievably important. Is the risk of the hypoglycemia, and there are unfortunate, reports and really situations when people really went on in alcohol drinking, especially with that food, and they are taking insulin or insulin secretagogue, and those are, the sulfonylurea class, glipizide, glimepiride, glyburide. It is really there is a risk of the low blood sugar happening. So this is really another conversation piece we try to share out patients. Please do not overdo it really with the alcohol, and especially if you're not going to be eating, there is a risk of hypoglycemia, which can be unfortunately which has led to loss of life at certain people not knowing that. And this is not, it doesn't have to be about, being overdosed or anything. It's just there is a risk of that developing with the alcohol. All right, so as far as the sweetener, again, there's no problem with that as long as you're not using this and then, adding them to a source of caloric, intake, and then you end up saying, well, I'm drinking diet this or eating diet that, but there's also other calorie sources of those diets. And then you may really end up losing the benefits. So the question is, again, you're always referring to the label, see what's going on, how many calories are in the food. So reading the label is an essential aspect of the medical nutrition. Now, obviously, as I mentioned, the medical nutrition therapy lifestyle changes are the foundation, for any treatment, but eventually, sometimes in certain people and many people will require medications. So what's new there? If we're going to our kind of essential, that first slides that I shared with you as to why diabetes does happen. So understanding where the problems are, we can then, the medications have been, worked and developed and discovered. When the deficit was discovered, then a medication was developed to try to correct it. All right, and so if you look at where all these all these defects are, and essentially there is a medication to counter effect the benefit that is happening. Whether if there is a lack of insulin production, there are medications that can push more insulin production from the pancreas. If there is a problem with the resistance to the actions of insulin at the liver or at the fat, tissue that we have, or at the muscle level, that we have the medications to counteract that. If there is a problem as far as how much sugar we are filtering into the kidneys, there is a medication to counter the effect of that deficit or the problem with the diabetes there. So you can see then our menu of medications have expanded over the years. And so with that, and that's really essentially a result of better understanding of what could be going wrong, leading to developing the high blood sugar. So when we are choosing from this, obviously it's like a toolbox, and the question is what to do and why do we, how do we choose the medication? And what has changed, for us over the past few years, really, again, shifting from what is the A1C that we need to get? Is it 6%? Is it 7%? Is it 8%? Yes, we do have that back in our mind, but I think the more important, or equally important, if you say, is how can we choose the medication class that is tailored exactly to benefit the entire health status of the patient. And the two major complications or other conditions that patients with diabetes unfortunately have is the cardiovascular disease, whether it's heart attacks or stroke or peripheral vascular disease, and also heart failure, and also the kidney condition, right? So if we, right now, obviously, everybody sort of goes on to the lifestyle changes, modifications, and as a step one is, in addition that and some people have already come to us already on metformin because they've started it, because they were pre-diabetics. And if they're not, we start that. But then, the key is the next step in our thought process, and that's really the message. As again, it's very important, is does the patient have cardiovascular condition? If someone already come to us and say, I've just had a heart attack, and many patients with diabetes get to be diagnosed when they unfortunately get their first heart attack, or if they've had an open heart surgery, or or they've had a stroke, and so on. And we get consults on patients who are admitted to the hospital with those conditions. Then we choose a certain classes of medication. If we know that they have heart failure or chronic kidney disease, then we can also choose a different kind of class of medication to begin with. And that's not to say this is the end of the journey, this is the beginning of the journey, but again, trying to improve those. And the reason why is that with those medications that I mentioned to you earlier, is there has been, again, focus in our evaluations of the medication. It's not like, okay, does this medication lower the blood sugar? If it is, then it's good, let's put it on the market. But it has been required now that the medications, when they get approved, they need to be evaluated to make sure that they are safe for the heart. And thankfully, a lot of these medications are not just only being proven to be beneficial, but sorry, they're not harmful, but they are not only that, they are beneficial. So in other words, some of these medications, and you can see that SGLT2, the one that works on the kidney, and then the one which is called the GLP-1 receptor agonist, short GLP-1RA. Those are two classes of medications that are over the past, close to now 7 years or so, 7 to 10 years, have been shown to not only help with cutting the risk of improving the blood sugar, but also they do improve the cardiovascular, the conditions. They reduce the risk of further cardiovascular events in patients with diabetes. So again, this is the change for us that has happened. And so you can see this, again, this is a busy slide, but this is kind of building on what I've just mentioned earlier. If the patients, if you look at the, heart, panel, obviously, then we will start with the patients, on the GLP-1 receptor agonist, or we can do the SGLT2 inhibitor, depending on what their kidney status is, and depends on how their progress.
You're muted, Dr. Makdisi.
Is that working now?
Yes.
Yes.
Okay. So I was just saying, as far as this, the choice of medication will be really primarily based on what the medical conditions of the patient have. If cardiovascular, will use predominantly is the medical condition, then we will use the one of those medications called the GLP-1 receptor agonist. But if the patients have a kidney conditions, then we will have to do we'll start with the SGLT2 inhibitor, and then, and progress to the next level depending on how the A1C is. So just to take you on the journey of the options, this is now a kind of a score card, if you will, to each class of medication. So the metformin, for instance, is as far as the efficacy, it gives the green light. It does help. It's kind of a little bit more of a weight neutral, or could help with some of the weight loss. As far as the hypoglycemia risk or the low blood sugar risk, it's got minimal low risk. So this is why it goes all the way, dial goes all the way to the green. And the same for the cost, because it's been on the market for a while, it's generic and it's cheap. It does, some of the studies have showed the cardiovascular benefit. It's kind of neutral for patients who have heart failure. And as far as kidney condition as well, it depends on the kidney clearance. And now there's more evidence you can continue treatment even if your kidney function is not all the way down. And there is a measure of the creatinine clearance, or a number, as long as it's above 30, we're able to continue even if we modify the dose. So that's with the metformin. And that other medications, the class, which is available as a pill or as an injectable. The majority of them are injectable, only one is available as a pill. And as you can see, there are 5 medications in that class. And again, this is the new thing about this is all fairly new class of medication. Good efficacy. They definitely help with the weight loss. There is really minimal or no risk of low blood sugar, developing on these medications. In fact, some of these medications have been approved in their own right as a weight loss medications, even for people who are not diabetic. The disadvantage of that is the cost. They tend to be more on the, so this is why you see that red dial happening, showing there, is because they are more expensive. But they definitely have cardiovascular risk benefit, and then somewhat renal benefit, and they are neutral as far as the heart failure. There are certain side effects or black box warnings, if you will, on these medications, and we definitely share that with the patients and let them know, and then ask about these risk factors. And so the patient is prepared, if any of the side effects were to, happen, and how to deal with that. The other classes is the new one, as I mentioned, the SGLT2 inhibitor. There are 4 oral medications that are available on the market for us. Similarly, they have a good efficacy. They definitely help with losing weight. Again, they are not associated with low blood sugar. They do have cardiovascular benefit for people who have had, blocked arteries, heart attacks. But also they have, and that's the other, the advantage of over the other classes. They are very helpful with the heart failure patients, and also with chronic kidney disease patients. But the disadvantage, just like the GLP-1 receptor agonist, is the cost. And that's unfortunately sometimes is the limiting factor for some patients not being able to get to be on some of these medications. Oftentimes we're able to process paperwork if required to get the approval, but sometimes it is a cost limiting factor. The milder form of these medications, another class, which is called the DPP-4 inhibitor. This is sort of good efficacy. They're weight neutral. They don't really cause weight gain or weight loss. They do not cause low blood sugar, but they are also, they are expensive, and they're really kind of neutral in general on all the other conditions, and that's why they've kind of fallen down, as far as the algorithm is concerned, as to when we jump on those. They are easy, they're very well tolerated, but the issue is that there is not enough, benefit that we can get based on a clinical trial with this class of medication when you compare them with the SGLT2 inhibitor and GLP-1. Some of the older ones right now, this is the this is the class that I mentioned to you, the glipizide, glimepiride. We don't have a lot of, glibenclamide here in the US. But again, there's very, very efficient, you can get a lot of efficacy from these medications. They are cheap, but the challenge is these two, right? There is a risk of low blood sugar and there's a risk of weight gain. And as soon as I utter the word weight gain, the patient says, no, and understandably so. And so the same thing, as opposed with the other class, which is the thiazolidinedione, or short for, TZD, primarily the pioglitazone. It is kind of not, it is generic. There is no low risk, but there is a weight gain, and that's a side effect that many patients obviously do not like. But also there is a risk of heart failure. It is not, we cannot use it with heart failure because it can be associated with fluid retention. All right, so I shared with you, I think, enough of the medications. Let's just move on a couple, as far as this, as far as your, how do we monitor the treatment? How do we monitor the effect of the treatment that we're using, whether it's medical nutrition or medications? And obviously everybody is familiar with the finger stick glucose measurement. That gives us a graph of what it is. What the number is, the snapshot on time, that time and point. But also we talked about the A1C, how to monitor. It gives us an average. As you can see, there's a lot of ups and downs here, but the average in this patient would be 7%. And that's kind of the report card that we share with the patient on their visit. But now everybody, obviously this has been on for a long time, but there is this monitoring continuously. So not only just taking a snapshot, not just taking an average, but I think really now going real life, movie action in a sense of what's happening on the blood sugar from, every 5 minutes to every 15 minutes. The difference is that tiny little needle is not really inside the blood vessel, is kind of in the tissues. And that's where sometimes we, there are differences in the measurement between and there's a little bit of a delay as to what the blood sugar reading that you see on the finger stick as opposed to the continuous glucose monitor. So there's this is where a lot of the advances have happened now. And there are now primarily those continuous glucose monitor sensors, what we refer to them, and the development that has happened is that they do not require, a lot of them now require no calibration, which is, they are taken away. It's just more of the ease of use. The technology is advanced. You can project the reading over to your phone or on the receiver itself. And then, obviously this one is the, the one which is implantable, which is the longer acting and can stay in for months. So this is the only implantable one. So oftentimes, as I said, there's in a way, a boom of use of these continuous glucose monitor systems and over the past several years. And the accuracy has, obviously evolved and improved with time. And this is what's happening on this front. What on the other front is the delivery of the insulin has also evolved over the years. Obviously, we have the vials with the needles, we have the pens, but also now, and that came back in a way. We had the inhaled insulin. It went off for a while, and then another manufacturing process and packaging happened, and what you see on the upper panel is the inhaled insulin available to us, which is a short-acting insulin that patients can use. And then the lower panel is the sort of a system which is not fully electronic. This is a mechanical delivery system to give the insulin, and this is more of will be attached as a patch on the skin directly with a needle inserted, so it can deliver the insulin over, as a basal, and then the patient can press a button to deliver a bolus. And this is kind of not the fully automated electronic pump that is available. Certainly, as far as the pump's concerned, over the years have changed. I could imagine, to my shock personally, how big that insulin pump looked when it first started to be, developed, to how compact and small, really, and discreet that device is. And what's happening right now, we have 3 systems available, from 3 different manufacturers, and they're pretty much the basic principle is the same. You can program the pump, and the pump is the hardware. But what it is there is the software that, inside it, which is really what we work with the patient on to figure out before we put the patient on, start the therapy, is to figure out how to program it so it works best for them. And that's really many of the challenges, where the challenge is for many patients, because some people will say, oh, can I go on the pump? Yeah, sure, you can do on the pump, but we need to figure out how the pump is going to work for you. And that requires some work. Including blood sugar testing, measuring the carbohydrates you're eating, calibrating how much you're going to use to cover that carbohydrate so we can program that pump. And, what has happened recently over the years is now we are kind of pairing together that insulin delivery with the sensing of the sugar. And this has been right now work in progress over the years. And it has kind of evolved from what we call it sensor augmented, where pump is available to deliver insulin, sensor is measuring the blood sugar. They work independently without a crosstalk. And then started, some of the earlier systems started to kind of, the talk is there, but not complete. In a sense, if the sensor is sensing a blood sugar that is low, it will send a signal, and the pump will suspend the insulin delivery at a level that is predetermined. Then it evolved more towards not only if the sugar is already low, now can we predict it? If it continues to decrease in that rate, then it is going to happen. The low is going to happen. So this is called the predictive low. And then that will send a signal, to suspend the insulin delivery, to eventually, what we call it, the hybrid closed loop system, automated insulin delivery, or sometimes artificial pancreas, in a sense referred to. And that system works is, the patient has both, and then the sense, it is a continuous crosstalk, right? So the sensor will measure the blood sugar, and then it goes into the algorithm. The algorithm, goes with the software that has been programmed, deliver the insulin. And then as the insulin is, rising or decreasing, then, on the sensor, that's sending back continuous talking into the algorithm to, if there is an increase slightly in the blood sugar, then the pump will give you microboluses to bring it down. And if it is really if the blood sugar is going down, then it will pull back the insulin delivery. So that's really now the most advanced system that we have available to us, to be used in patients. And this is primarily used in type 1 patients with type 1 diabetes. But rarely that we have to use that in patients with type 2. All right, I think right now, so I've kind of shared with you how to deal with the diabetes, how we manage it, how we monitor the blood sugar. And I just want to spend a few minutes, just talking about some of the challenges as far as the diabetes and the COVID, that cross relation, if you will, the relation that's been happening over the past couple of years. And I found this actually referenced in an article, which kind of summarizes exactly what we've been dealing with, healthcare professional and, patients together, how to kind of, how we are fighting that epidemic, or two pandemics really colliding in a sense. So the diabetes pandemic, as I shared with you, has been going on. And as the COVID, the infections started to happen, there were a lot of concerns about how our patients with diabetes are going to kind of fare in that new pandemic. Will the vaccine work with them? How are the medications used, for diabetes? Will they impact the COVID course? And what do we do if, how is the blood sugar if we have a patient who's well-controlled diabetes versus someone who isn't controlled? And how is that going to impact if they get a COVID infection, how they're going to fare? Are they going to be at a higher risk of complication? And sure enough, that was the situation. And now we're kind of going back as well, as part of that is how do we, there's an interaction in the other way happening when the COVID started. Obviously, there was a big, burden where there was a diversion of the resources, from the health system. A lot of patients, I can tell you, they didn't know if they can still access care. Some of them were fearful. They didn't want to go out. They didn't even know that telemedicine is really available. So they canceled appointments. So there was a lot of, issue with access to care. Plus, that lifestyle, the trips, what I call them, the exercise, the only exercise we've done is to the trip out to our fridge and come back to, the desk or to the, the sofa to watch TV and go back and forth. So that impact of COVID-19 on the lifestyle. But then at the same time, the positive aspect that has kind of catalyzed the implementation of the diabetes technology. A lot of these, what I'm shared with you as far as monitoring or treatment, now we can even remotely monitor patients. And we have a cohort of a number of patients who are actually sharing their continuous glucose monitor readings with our practice. And we can just say, they can call us and say, I'm having trouble. We log in, they log in. Obviously, they gave us permission. And we can look at their data and we can say, okay, this is what you need to go up or down on your treatment here or there. Obviously, after we, a few more questions to understand the details. And a lot of you have heard about, the concern as, is COVID is contributing to the worsening of the diabetes pandemic? Is there any concern about newly diagnosed diabetes after COVID-19? So just a summary again, it is now kind of established if you have diabetes that is well controlled, you do better. As far as survival, you're definitely, so that's a message that we repeatedly share with our patients. You really need to, for anything else, if you forget it right now, you really need to keep your diabetes under well control. Good control, so you can avoid the risk of complications, severe complications, and increases the chances, of survival if one were to get an infection. As far as as far as the concern about whether COVID-19 is really, is contributing to the newly diagnosed diabetes. And this is, if you look at the first from the New England Journal of Medicine, this is in the early days of diabetes. There was a letter, to the editor, but this is back in from June 2020, early in the pandemic, to the more recent report, and I'm sure a number of you are familiar with it, where this is from the morbidity and mortality weekly report from the CDC, just really last week. Or a couple of weeks ago, where there was a statistical analysis raising the concern of newly diagnosed type diabetes in among persons less than 18 years of age. This is looking at the number of diagnoses going back from the beginning of the epidemic until June of last year. So, as far as to why that has happened, obviously there's a number, again, of theories what could be possibly happening. And one of them is that some of the study pointing that the virus has been found in that factory of pancreas, the factory of insulin in the pancreas, in the islet cells. So they have identified the virus present there, and that may have contributed to, as far as the ability to make and secrete the insulin. And then obviously, as this graph shares with you, the infection really is kind of amplifying the state of inflammation, the state of resistance to the insulin, whether it's the infection itself or the medications that we're using to treat the infection, such as the steroid. It's in a way amplifying, how diabetes occurs. So in other words, if we get the infection, obviously as a patient with diabetes and then certain other risk factors as just being pointed here, whether it's older age, male sex, and then the ethnicity, lower socioeconomic status, all is kind of drifting that path toward a severe COVID. And on the way, we are creating a state of potentially reduce of beta cell function, where the insulin manufacturing process is slowing down, but also we're creating an insulin resistance. So in a sense, kind of, if you look at the bottom, picture, it's kind of exactly what the picture similar to why diabetes happens to begin with. So that may be one of this is kind of the working. And obviously, there's a lot more detailed work as to more of on the cellular level as to why COVID, or SARS-CoV-2 is really resulting in potentially contributing to the newly diagnosis of diabetes. So I want to then, good on and hopefully on a more hopeful, note. So this is really kind of much more of the innovations as this is really going back. Definitely, our neighbors in Canada have that right to really a major breakthrough in science. Now 100 years ago, where the scientists were able to identify and get the insulin started, and that was an incredibly major breakthrough from our neighbors there. But Buffalo is also strong, and I am very proud to be part in in the diabetes endocrinology center of Western New York and the UB division of endocrinology. We are very proud to be also at definitely not inventing the insulin, but we are really doing what I consider significant work really in the world of diabetes. And Dr. Dandona, as an example, for instance, was the lead investigator on the multi-center worldwide research, the clinical trial investigating the effect of one of the medication that is approved for the treatment of type 2, but then studying its effect on patients with type 1. And our center has been involved in these kind of studies, I can tell you, since 2010 or so, with multiple studies looking from small number of patients participating to a larger trial with different various fundings. But this is one of the trials that Dr. Dandona was leading, along with a lot of investigators worldwide. I can tell you that this is one of the studies that have been, kind of a basis in a sense to help approving, not in the US, but in certain parts of the world to start using an oral medication in conjunction with insulin in patients with type 1. And that work continues until this day. And this is an example of another trial right now. We are, working with, the UB as a major, the primary sponsor in a sense, and then the collaborator from the University of Glasgow in UK to study further the effect of an oral medication and, one of the medication from the SGLT2 class inhibitors, and then and in combination with the medication of the GLP-1 receptor agonist, which what we refer to as a triple therapy study, to study the effect on patients with type 1 diabetes. And we're currently, obviously, this is an active study in those two sites. So these are, on the local level, but there are some exciting, and again, this is some of the questions have come prior to the session. What else is going on? This is, as you can see, a very busy slide, but this is reflecting the elegant work, group describing the FAPKIN, which is, in a sense, looking at the actual access right now of the what is referred to as the adipose tissue or the fat tissue under the skin, and its relation to the islet cell, and to the islet cell, which is the source of the insulin production. And so this hormone is identified, and it seems to be playing a major role in regulating. This is again very preliminary data, and this is primarily in animals. So there's a lot more work. It's very preliminary, and so we cannot really say yet on how it's going to be. How it's going to pan out on the human level, but definitely this seems to be very promising in terms of identifying another target for us, potentially to explore a therapeutic option with this, the FAB, what's called as the FABkin. So that's one aspect. And then equally exciting is the study related to the islet cell. So the islet cell that's referred to here is the VX880, which is in a sense an allogenic stem cell derived insulin producing cell, but has been sort of done or derived in a proprietary way that has been developed. And the good thing is that now you can, generate as many cells as possible or as you like. And the idea is if you can infuse that in patients, then you could potentially substitute or compensate for the lack of those, insulin producing cells. So this is, as you can imagine, this is going to be in patients with type 1. And this is an example of the phase 1, phase 2 study right now being looked at in patients with type 1 who have no awareness for hypoglycemia, and they have developed the severe hypoglycemia. And so this is recently they've shared with us a study from the results from patient 1. This is an example of a patient. The patient was, had no insulin production. The A1C was 8.6%, and the patient was requiring 34 units a day. And then 90 days after the infusion of those, in a way, insulin producing cells, the insulin dose has gone down all the way to 2.9 units per day, and the A1C is, 7.2%. So obviously, this is a promising. Again, this is not a mainstream, therapy yet, but we're eager to see if there's any more. How are the other patients, and how are the other enrollees will do on this trial with this therapeutic intervention. All right, so I wanted just to conclude again, as I mentioned in the beginning, earlier, this is now the anniversary of invention of the insulin. So I thought I'll conclude with this video, and then I'll be happy to take any questions.
100 years ago, in a cold, bleak winter, hopeful word came from a Banting Invest of health and progress for those with pancreas suppressed. 100 years ago, a faint and failing boy received his first shot. The brown muck revived, the insulin restored, his frailty soon forgot. 100 years since, boys and girls, young and old, live their birthdays, weddings, and lives in control. 100 years since that first day of insulin, lives preserved, lives with less incidents, yet 400 million today with lives still independence. 100-year birthday for that first day of insulin. Let's not wait 100 years more to find a cure, but let the joy of a free life become our blood's natural stimulant. 100 years from now, our lives better and stronger, with insulin no longer our aid, newfound strength, newfound lives for millions and millions. Together, this is our crusade.
All right, thank you everyone for listening. I want to just thank you, the organizer, but I also would like to thank my patients, because I think they are they're my continuous education every day of my life. So thanks for listening.
Dr. Makdisi, just thank you so much. This was a comprehensive but very understandable, can I even say digestible, discussion of diabetes, from pre-diabetes all the way into the future. Just absolutely wonderful. And I want all of our students to know that Dr. Mastrandrea was unable to be with us this evening. So Dr. Makdisi actually put together even more of a talk than we originally anticipated, and obviously incorporated many of your questions. So thank you so much. We are really grateful. I do want to add one fun fact, though. I always get the opportunity to do that. And it has to do with nutrition, because you did spend a lot of time on lifestyle management. And in fact, the plate method is one that I have to admit I use because it's simple and I don't have a lot of background in nutrition. But the fun fact is that since the beginning of the 19th century, the American plate has increased in size by 25%. That's the reason we have diabetes. And in fact, in 2000, the average American plate was about 11 inches. In the beginning of the century, it was less than 10. Now it's bordering on 12 inches, but in Europe, it is still around 9 to 10 inches. So I think that's interesting. So use that plate method and get a smaller plate. That's my tip.
Actually, well said.
Okay. Thank you. Yes, somebody called it supersizing. Yes, we supersize everything, including our plates. So I want to thank you all. I really don't see any questions in the chat, and I think most of them were really addressed in advance. I just wanted to say thank you and remind our students that the video will be placed into our MiniMed site. And there was a comment about getting more medication, more information on type 1 diabetes in children, which is what Dr. Mastrandrea would have discussed, and we will work on incorporating some information on the pediatric side in future programming.
It's also another question, Dr. Berger. Becky Burke is asking a question regarding infusion treatment.
Oh, okay. Sorry, I missed that. Oh, there it is. Yes. The infusion treatment is in its early stages, but do you see it as a one-time treatment or many times? Oh, I think you're muted.
Yeah, no, I would like to know a little bit more as far as the viability as well of that one infusion versus multiple. I would love to have more details to share with you, but I don't at this point in time. Yet to, I'm sure there will be more to be known about it.
Okay. Again, what you've already demonstrated is we keep on learning so much more, particularly with those active trials that are going on here in Buffalo and elsewhere. So again, thank you. Thank you to Independent Health. Thank you to UBMD. And a special thank you to all of our students who have joined us this evening. We look forward to seeing you again at future mini medical schools. So good night, everyone.
Good night, everyone.